Good evening, everyone. We're just going to give a minute for everyone to just join in. All right, so we're going to get started. Thank you very much. So welcome back to our Grand Round series, where we today are going to touch upon a very important topic of coronary atherosclerosis. But before we go there, let me just do a usual routine of trying to bring you to our cardiology Grand Rounds web link. So here is where you will find all the previous Grand Rounds being hosted. And if you would like to get your CME credits for the session, please text right now 12459 to the number 888-816-4893, 12459. And here is an opportunity for you to get your CME credit for this specific session. Please send us a SMS message and not as an iMessage. And you need to make sure that your mobile number is recognized within the cloud CME. We also offer the MOC points for physicians. And for that, you'll have to complete the step 1 I just indicated. And you would have to use a brief response to the quiz, which will be available at this link. And this link will be provided also in the window during the presentation so that you can go ahead and link it whenever you have a chance and opportunity to go in. The room code is future 11. All right, so it's my distinct privilege and pleasure to bring to you one of my colleagues, a great friend, and a great scientist, Dr. Jim Min. Dr. Min currently is the CEO of a company, Clearly Health, which he has formed during his academic career at Weill Cornell. And my association with Dr. Min was when I came on to the editorial board of JACC Imaging, and I soon found how profound he was with his understanding of cardiac imaging. His initial formative years he spent working on echocardiography, and then his career took a twist, and when he went to multimodality imaging, and he contributed enormous science in coronary CT specifically, where he continues to have a lot of his current insights on. He was the director of Dalio Institute of Cardiovascular Imaging at New York Presbyterian Hospital at Weill Cornell Medical Medicine at New York before he went on to his venture at Clearly. And during his academic stay at Weill Cornell and previously, he has had an outstanding illustrious career with tremendous scientific contribution, which includes host of NIH awards, several R1s, U1s. He has several honors and awards, including gold medal from SCCT. He has contributed to over 400 peer-reviewed publication and countless numbers of presentation at National Society, and he has himself steered a lot of the developments that have happened in the space of CT, coronary imaging, and so on and so forth. And today he's going to give us his insight into his topic that he's extremely passionate about, and that is on atherosclerosis. So without any further delay, it's my great privilege to introduce to you all Dr. Jim Min. Jim?
Great. Can you hear me, Partha?
Yes, we can all hear you.
Okay, it's an honor to be participating. Partha and I go back longer than I care to admit. Like, we were young when we met each other. We're no longer young anymore. And at the time, I was at Cornell Medical College and New York Presbyterian Hospital on the Upper East Side of Manhattan, and then have since transitioned out into a startup. I won't talk about the startup. Happy to answer questions at the end of it, but this is literally just about the science that we had done and that we continue to do today. And so I'm going to spend about 45 minutes trying to talk to you about this topic here of why atherosclerosis is all that really should matter. And let me just start with my disclosure. So I still do research. I still carry a couple of R01 grants, and then still do some work with the ischemia trial on the U01. And as Partha noted, I do have equity interest and serve as an employee for a company called Clearly as well. I'm just going to start here, with a quote. And so this is a quote from Albert Einstein, who said, if I had an hour to solve a problem and my life depended on it, I would use the first 55 minutes trying to figure out what the proper question was to ask. And so when we think about coronary heart disease, I think that we've asked all the right questions. I think that we just have asked them in completely the wrong order, right? So if I think about coronary artery disease, I think of it as a primary atherosclerotic process. And then at some point, the atherosclerosis may encroach upon the lumen of the vessel and cause a narrowing or stenosis. And at some point, that narrowing may impede blood flow and cause myocardial ischemia. And so when somebody comes to us, what do? We get a stress test to look for ischemia as an indirect marker of whether they might have a stenosis, and we send them for an invasive angiogram. And that's the approach that we take. So if you think about it, our approach to valuing heart disease doesn't measure heart disease. It measures consequences and sequelae of the atherosclerotic process. And we hope that by treating those sequelae that we will actually make a dent. And I'm here to argue that we should focus on atherosclerosis as a primary disease target rather than consequences or indirect markers of the atherosclerotic process. And as Partha alluded, we adopted coronary CT angiography simply because we felt that it was a really good tool to better understand vascular biology. And certainly since the introduction of 64-slice CT scanners in 2005, we've seen the evolution of this field so that now we have 640-slice scanners, and we can do whole heart imaging in less than a second. We can do it for radiation doses that are as low as a screening mammogram. And then the payment for it is pretty cheap. And so it ends up becoming sort of just another lab test that you could order. And I think that the field of coronary CT angiography, when it wanted to try to evaluate this technique, really started with this sort of reverse order questioning, where the first 5 years or so of the field of coronary CT angiography was really focused on, can this CT scan measure stenoses like an invasive angiogram? And then I think from 2010 to 15, you saw a lot of excitement in the field of trying to figure out, can this CT scan figure out whether or not this vessel is ischemic or not? And then over the last 5 to 6 years, I think what we've seen is the evolution of the field into focusing more on the primary disease process, which is atherosclerosis. So, just in keeping with that Einstein quote, I think if you take this patient here, a 63-year-old man with chest pain on exertion, and you perform a coronary CT angiogram, what's the question that you're trying to answer? And I think that for all of us, because we've been taught that we're looking for stenoses and something to revascularize, I think that the first question that we ask ourselves is there a high-grade coronary stenosis within this person's vasculature? And then for that, the field has actually done some, I think, very good foundational research to understand how good is a CT scan compared to a gold standard, if we use invasive coronary angiograms, to both identify as well as exclude at greater than 50 or greater than 70% stenosis. Here are the 3 multi-center clinical trials that really have spoken to that, using a core lab to do quantitative coronary angiography and comparing CT angiography for the detection or exclusion of that high-grade narrowing. You can see that they're all across different prevalences of disease, which will obviously influence the sensitivity and specificity. But both in the accuracy trial as well as this European trial by Majboom and colleagues, both the sensitivity to detect as well as the negative predictive value to exclude obstructive coronary stenosis was very high and approached 100%. These were in patients without known coronary disease, and patients with like a heterogeneous mix of patients with and without known coronary disease. Then the results change a little bit. But then so this was probably 2008, 2009, we saw these multi-center clinical trials published. And then the diagnostic performance of CT, I think, was generally well accepted, that like it could do what it said that it was going to do. We did see a paper come out last year from John Mancini and other folks from the Ischemia trial, where CT was always used as sort of an enricher, right, to identify patients who had obstructive coronary stenoses, and then to rule out patients who had left main disease. And for that, what you can see is that the agreement between a CT angiogram and invasive angiogram is fairly high for the detection and exclusion of obstructive coronary stenoses, and then also very good to exclude left main stenoses as compared to an invasive coronary angiographic reference standard. So around 12, 13 years ago, we used to put up this slide and say, you know, I think it still holds true today that when you compare a CT angiogram to other measures that we've historically used, if the question that you're asking is, does this patient have a high-grade coronary stenosis, that for patients without known coronary disease, there's really no better non-invasive diagnostic test available to us. I think in that 2008, 2009 time frame, then people said, well, you know, just because we see a high-grade stenosis doesn't mean anything clinically. And so you really had to prove out the prognostic utility of these findings. And there's just been hundreds and probably thousands of papers on the prognostic utility of coronary CT, looking at increasing levels of stenosis, whether it's normal, non-obstructive, or 1, 2, 3 vessels. Do these people have a greater than 50 or greater than 70% stenosis? And in the confirmed registry of more than 23,000 patients from 18 centers, followed for about 2.5 years, what we found was that there was a very predictable stepwise decrement in survival, even in the short-term follow-up for patients who had identified coronary stenoses by a CT angiogram. And it's not in only the people that we would expect it to be, but it's in also people who surprise us, right? So both in patients with low Framingham risk scores or patients with no treatable coronary disease risk factors, the presence of that high-grade stenosis connotes a 3- and 4-fold increased risk of major adverse cardiovascular events just by having that high-grade coronary stenosis. Subsequent to that, like there are a whole host of subgroups that were analyzed to make sure that this relationship did in fact hold true, that on the x-axis, the extent and the severity of angiographic coronary stenosis by a CT scan correlated to the y-axis, which was risk. And suffice it to say that like it always performs, that this relationship holds true. The more stenosis you have, the higher the risk. What we don't typically show, because we always talk about relative risk, is the absolute risk of somebody who's down here, right? Because we're always comparing to the normal and comparing the abnormal to the normal. Well, the person, it turns out that's the strongest predictor for CT, is that if you have a CT scan that looks like this, so this is somebody who not only doesn't have any stenosis, but doesn't have any atherosclerosis, that when you look at the absolute annualized event rates and you plot them against studies, you can see that the warranty period of these people who have a completely normal CT scan is is over 10 years. So the question is like, how do you use this in clinical practice to your benefit? I think you can take this normal CT scan and leverage that with great utility. So we had done a large-scale randomized control trial called CONSERVE, and the question that we tried to ask and answer with CONSERVE is like, can you use CT as a judicious referral management tool to get the right people to the cath lab and the wrong people out of the cath lab? And what you see here is 1,600 patients who had stable coronary disease, suspected coronary disease. They were symptomatic and they were being referred to the cath lab based upon an ACC/AHA class 2 guideline. That means class 1, they should definitely go. Class 3 is definitely contraindicated. So it's everybody in between. And they were randomized to cath the way that they were being referred versus a selective cath strategy where they would undergo a non-invasive coronary CT angiogram first, and then the doctor could do whatever the doctor wanted with the findings. There was no mandate afterwards. And in a 12-month follow-up, what you saw was that, once you underwent a CT guided strategy, a selective cath strategy, you saw a more than 75% reduction in invasive angiograms in that population, which was associated with a 45% decrease in coronary revascularization and a 50% reduction in cardiovascular costs. So it seemed to be highly efficient at reducing unnecessary resource utilization, provided that it was safe. And so when you look at the MACE rates of the direct cath versus the select cath strategy, they were identical. And when you looked at the subcomponents of all of these, they were also identical, suggesting that we can leverage this sort of warranty period to our benefit to get the right people into the cath lab and keep the wrong people out of it. That was sort of 2005 to 2010. And then when we come back to our patient and ask ourselves, what is the question that we're trying to answer? I think that 2010 to 2015 was, well, we can do a high-grade stenosis, but really, is this lesion ischemic or not? Is it causing this patient's symptoms? And you saw just a slew of debates of nuclear versus CT and whether or not something, is high-grade stenosis versus ischemic and whatnot. And, some of those debates were very well suited because CT is actually, anatomy and physiology don't correlate very well. There's a discordance sometimes, where you can see in this study by Majboom and colleagues that when you call a greater than 50% stenosis, it turns out the majority of those lesions don't actually cause ischemia. And so if you send them to the cath lab based on just a high-grade coronary stenosis, that you'll probably be wrong and just results in unnecessary wasteful invasive angiograms. And here's just two patients who sort of signify that. Like you can see in the first patient, this is an LAD with a high-grade coronary stenosis. This is a right coronary artery lesion, also with a high-grade coronary stenosis, but only one of these patients actually has ischemia when compared to an invasive FFR reference standard. And I can tell you it's this LAD one, not this RCA one. So then the question came about like, well, we understand all of these things that we're seeing on a CT scan, but we don't understand how to relate them to ischemia. And so the question arose, can atherosclerosis improve the identification of ischemia? And so here I show you 6 different patients with arrows pointing to 6 different lesions. And I can tell you that only one of these lesions causes ischemia. And I could also tell you that you can figure that out just looking at the morphologic appearance of the atherosclerotic plaque, because it turns out that the plaques that cause the lesion and the plaques that have a certain phenotypic appearance, it dictates their behavior of whether or not they cause ischemia or not. And I can tell you that the highest grade coronary stenosis looks like it's right here or here, but it's actually this lesion that's actually 3 lesions, 1 lesion here, 2 lesions, and 3 lesions. This is the vessel that is experiencing significant ischemia. So how do you figure that out? Well, that sort of brings us to this whole topic of atherosclerosis, right? We know if you take an LAD over here and you cut it up into cross sections and you start to look at the lumen and then the juxtaposed atherosclerotic plaque, that the plaques are totally different. Some of them are really bright white, some of them are really dark black, some of them are gray, some of them are pushed outwards, some of them are pushed inwards. And it speaks to all of these different features that we can figure out from atherosclerosis, whether it's be plaque burden, location, length, eccentricity, direction, diffuseness, composition, and so on. So there's so many different features that we can look at to try to better understand whether or not this atherosclerosis is actually contributing to ischemia within this vessel. And the way we figured this out was honestly just pure dumb luck. Like we had done this trial that we had designed, I think in 2011 or 12, called Credence. And the goal of Credence was not actually to study atherosclerosis. The goal of Credence was to compare that sort of stress test versus CT scans, because like that was the time that we were seeing all those debates of which one's a better diagnostic tool. And so the idea here was that like whenever people talked about the ability of a stress test to identify a functionally significant lesion, all they did was look at the perfusion abnormalities. And we said, well, that's not fair, right? The stress test not only offers you all this perfusion, but also ejection fraction, wall motion, exercise time, other high-risk markers like transient ischemic dilatation and whatnot. And then similarly, everything that looked at CT's ability to determine ischemia just looked at stenosis. And we said, well, that's not fair either, because stenosis, I mean, CT can also look at all of these atherosclerotic plaque features. It can even look at this fractional flow reserve that's derived from the CT scan. And so we wanted to take into account all of these things that a stress test can offer, all of these things that a CT can offer, and then compare them head to head to figure out who is ischemic as compared to an invasive fractional flow reserve reference standard. And so the models that we built for stress testing myocardial perfusion imaging were 3 models, one that took into account all those perfusion abnormalities, then added in ejection fraction and wall motion, and then added in high-risk markers like TID and ST segment depression, things like that. And then with CT, similarly, it was 3 models. It was starting with, do you have severe stenosis? And then adding in the atherosclerotic plaque features, and then adding in this FFR-CT. And to cut to the chase, CT was a lot better than myocardial perfusion imaging for diagnosis of vessels that cause ischemia when compared to an invasive FFR reference standard. In fact, the area under the curve was 0.83 in orange here versus 0.68 for stress testing for determination of ischemia. So we said, okay, well, CT seems to be quite good at determining whether or not a vessel is ischemic. What is it about CT that's actually predicting the ischemia? So when we look at each one of those 3 models, it turns out that stenosis is not a half bad way of trying to determine whether or not somebody's ischemic or not. The area under the curve is 0.82. And then when you add in the atherosclerotic plaque features, you can see that it jumps to 0.88. And then when you add in this FFR-CT, actually nothing happens. Like, so you don't actually need this FFR-CT. Everything you need to understand of whether or not a vessel is ischemic is embedded within the scan itself. And so then we said, okay, well, amongst this model 2, what are the features that are driving that? It turns out it's severe stenosis. It's the number of lesions, so the diffuseness of atherosclerosis across the vessel. It's the plaque volume, so the non-calcified plaque volume. It was the lumen volume. It turns out 3D measures of luminal integrity and size was important. The smaller the lumen, the more likely you were to be ischemic. And then it was these quote unquote high risk plaques by CT, which include big, bulky, low density, outwardly remodeled plaque. And the combination of each of these 5 represented the optimal way for determining whether or not a vessel was ischemic or not. And it turns out, like, just so you know, if you say, well, all I have is stenosis at my disposal, that's probably good enough, because quantitative CT stenosis was alone, just this one, was superior to both myocardial perfusion imaging and FFR-CT for the diagnosis of ischemia. So you just need a really good stenosis measurement, and you can get pretty far there towards answering the question of whether or not this patient has ischemia or not. So that brings us back to our patient. If we know now that the patient, we can identify and exclude high-grade stenoses, and we can identify and exclude coronary ischemia, are those the questions that we're really trying to answer? I mean, now what we talked about was now we've got a bunch of things we're looking at: stenosis, plaque burden, plaque type, arterial remodeling, plaque location, all this kind of stuff. And I think what the patient actually wants to know, I don't think the patient actually cares if they have a high-grade stenosis. And I actually don't think the patient even cares whether or not they're ischemic or not. I think what the patient cares about is whether or not they're going to have a heart attack or not. And this was sort of, this is where I think we need to really focus on atherosclerosis, because it's the most prognostically important thing. And so we know this dating back to 2013, when Martin Hadamitsky had done a large-scale clinical trial on CONFIRM, looking at almost 14,000 people followed for 3 years for major adverse cardiac events. And he wanted to develop a risk score. And he's like, look, I just want to ask the question and answer the question, like, what's most important? Or is it this clinical risk factors? Is it severe stenosis? Or is it just plaque in the absence of severe stenosis? And what he did was he derived and validated a score where the sum weighted prognostic significance of all of these things favors atherosclerosis as the strongest predictor of risk. Like, I mean, it's a great study, but I don't think it's anything that's really that surprising to us, right? Like, for 25 years, we put up this slide to show that the majority of patients who will have a heart attack will not have a severe stenosis and will be expectedly non-ischemic. And yet we just keep focusing on this greater than 70% stenosis population, which only comprises 14% of the people who experience MI, when nearly 70% of the people will just have a low-grade stenosis, but they'll have atherosclerosis that causes their MI. So this has been criticized a lot. They said, like, look, there's a selection bias from people undergoing invasive angiography and prior to their MI event and things like that. So what the field of CT allowed for was to do a non-invasive sort of evaluation of large populations of people, because this was just like 100 people. So the first thing that the field of CT really did was just take out all the severe stenoses and ask the question, does mild stenosis actually connote any risk? And this was a paper that was published by Fei Lin and published in JACC, where she said, okay, in all of these 2,500 patients who have a less than 50% stenosis, like, is there a dose response curve where the more mild stenosis you have, the more death you will experience within a three-year follow-up? And what she found was that there was a more than six-fold increase in death in patients who had these mild lesions. And they're depicted here, right? So what you see is an angiogram of an LAD. I mean, the proximal portion looks like there might be some mild luminal regularities, but nothing really to write home about. When you look at the CT scan of the same patient, it actually looks pretty good too, right? There's no severe narrowing within this artery at all. But when you look at the sheer amount of disease that's embedded within the walls of this person's arteries, it's ridiculously how severely diseased this patient is. And because they don't have severe stenosis, they don't have ischemia, they don't have symptoms, we just never find these people as they develop such severe and diffuse coronary atherosclerosis. So then what the field wanted to do was really to try to better understand this atherosclerotic process. And so the confirmed investigators banded with some other investigators and formed a registry called Iconic. So this was a 25,000 patient study, 13 sites, 8 countries, and these patients were followed for about 3.4 years. And what they found was that about 234 of these patients experienced a heart attack after their CT scan. So they were stable at the time of CT, and then sometime in the future experienced an acute coronary syndrome. And they were matched on a one-to-one nested case control basis to patients who did not experience an acute coronary syndrome. And they were matched for age and gender, for site and country, for coronary disease risk factors, and even the percent stenosis, the angiographic coronary disease extent and severity. And the first thing that the Iconic investigators wanted to know is that John Ambrose slide true, where the majority of heart attacks are caused by low-grade coronary stenoses? So they looked at these patients who would experience MI and then classified them on a per patient basis as well as a per lesion basis of whether or not these lesions that were causing heart attacks were actually high-grade coronary stenoses. And similar to Ambrose, like who found 68% of the lesions were non-obstructive, the Iconic investors found that 65% of the lesions were less than 50% stenosis, with only 12% of patients experiencing a high-grade coronary stenosis prior to a heart attack event. And so then I said, well, maybe it's the lesions that are high grade. It turns out they're not. Only 4% of the lesions that were 70% or more caused the heart attacks, where more than 3 out of 4 lesions that would cause a heart attack were actually less than 50%. And so what the Iconic investigators sought out to determine, as you'll recall, was they said, no, it's got to be about the plaque, right? It's the atherosclerosis that matters. And it turns out they were wrong, like we were wrong. The total amount of plaque between patients who would versus would not experience heart attack actually did not differ, nor did the calcified plaques, nor did the fibrous plaques. But once you started to get to these very low density, fatty, cholesterol-ridden plaques, that's where you found the difference between patients who would versus would not experience heart attacks. And similar to this, like when you look at the very low density dark plaques on CT that are representative of necrotic core and cholesterol-filled plaques as dangerous, then the opposite must be true, right? Like the higher the density, the more the calcified, they should be protective. And in fact, that's the case. There was a paper that we had published in JAMA Cardiology about 1.5 years ago that started to look at bright, dense plaques. And so we know those are calcified plaques, but we know that there's some differences between calcium. You look at this calcified plaque, it looks sort of bright. And you look at this calcified plaque and it looks really, really bright. And so what Alexander Van Roosendaal did, he was a very, very clever fellow who came to our lab from Jerome Bax's lab, said, well, look, I'm going to cut this off at a really high brightness, greater than 1,000 Hounsfield units, and I'm going to call these 1K plaques. And then I'm going to call these calcified plaques that are non-1K plaques because they're under 1,000 Hounsfield units of brightness. And what he found was this continuous relationship that as you went from darker to grayer to lighter to brighter to whiter to really bright white, there was a continuum of risk, so that the darker the plaque connoted the higher risk of MI, and actually the brighter the plaque connoted a lower risk of MI. And so what we found was a pathologic determinant of MI, as well as a protective factor against MI. And so now what we're doing is we're starting to get into this field of like where Partha sits, right? So Partha sits solidly in this whole revolution of artificial intelligence machine learning. Because I'm going to tell you that we don't have enough in our brains, or we don't even have the tools with traditional statistical logistic regression models to be able to account for all of the factors that we've just been discussing. There's just too many dimensions of data, and we have to somehow reduce all of those dimensions of data into a simple clinical output where we can say high-risk plaque versus non-high-risk plaque, or future culprit lesion or non-future culprit lesion. And that's what those Iconic investigators did. They said, look, we're going to look at 4 different things. The first thing that we're going to look is just percent diameter stenosis. The second thing we're going to do is look at what the field has been labeling quote unquote high risk plaque. And then we're going to get down to the lesion level, not just the patient level. And then we're going to take all of those things and we're going to dump them into a machine learning model and tell me, is this person going to have a heart attack, or is this person going to have a heart attack? And it turns out you can do that with an area under the curve of about 0.77 as compared to diameter stenosis, which is about 0.59. And it takes into account all of the data that we've been talking about. So the start of a lesion to its minimum luminal diameter, the plaque volume, the area of stenosis, the calcium, the non-calcified, and so on. And so, you know, the only problem with Iconic was, I think it was an Iconic study, but it was, its problem was that it was 1-to-1 nested case control. And that means that 50% of the people had heart attacks and 50% of the people didn't by design. Well, that's obviously not real world, right? So what then the field did was test it in an all-comers population. And who could think of a better one sort of than a population-based study, and then compare that to the Ischemia trial, right? So if you say to a cardiologist, like, well, I've got 100 units of plaque, is that a lot? It turns out we as a field do not actually know what is normal and what is abnormal for heart disease because we've never actually measured it. And so in the Miami Heart Study, which was led by Khurram Nasir and Jonathan Fialco, they did a population-based study of about 3,000 people who just volunteered to undergo a coronary CT angiogram so they could figure out the distribution of atherosclerosis across the general population. It turns out the 90th percentile was about 500 units of plaque, and it turns out that 90th percentile equated to about 500 units of plaque, which was exactly the median amount of plaque within the Ischemia trial. And so we ran quantitative atherosclerotic analyses on the Ischemia trial. There were about 4,000 patients presenting it at the AHA late-breaking clinical trials this past November. And what I can show you here is that whether you look at stenosis or whether you look at any of the atherosclerotic plaque features, they're all predictive of who's going to have non-fatal MI or cardiac death within a 3-year follow-up. So if we can say the questions that we were asking sort of evolved from, is there a high-grade stenosis or not, to is there ischemia or not, to can I leverage the atherosclerosis to figure out, am I at risk or not? Now the question that I'll ask you is, are there any other questions that we're trying to ask and answer? And I would posit that the most important finding is actually not embedded in this image, because if you look at sort of the way that atherosclerosis evolves over time, it's dynamic. And we always think of a patient as a single point in time, but in fact, you know, over the course of their life, they will change as we give them medications, as they change their lifestyles and whatnot. And so I show you 3 patients here, all who had scans in 2017 and a repeat scan in 2019. There's 3 of these patients. They were all treated with high-dose statins after their CT scan. This person, you can see, regressed. This person has the same amount of plaque, but now it's starting to calcify over here on the right. And this person, despite treatment, actually progressed and then experienced an ST elevation myocardial infarction. And so what I'll say is the way that somebody progresses over time is the most important determinant of their prognosis. We know this from a paper that was published by Jagat Narula and Sadako Motoyama, who said, okay, I'm going to look at three things. I'm going to look at what the CT field is calling high-risk plaque. I'm going to look at a greater than 70% stenosis, and I'm going to see clinically, did they have a prior acute coronary syndrome or not? And you can see even on this, the high-risk atherosclerotic features connote risk that is 4 times more predictive than even having a prior MI. But then they said, well, we're going to add these together and see if they're synergistic. We've got a greater than 70% stenosis. We've got high-risk plaque. If you've got both, now you've got a 17-fold hazards ratio of experiencing a future major adverse cardiac event. And it turns out the strongest predictor of an event was whether or not you were a rapid progressor or not. So people who come in like this with atherosclerosis, but then significantly increase the progression of their plaque over time, that actually connotes by far the worst prognostic indicator of who will have an MI and who won't. And what I'll say is this, like, this person has severe diffuse atherosclerosis to begin with, and then they still have severe diffuse atherosclerosis. I think we have to go to a different mindset where we try to emulate atrial fibrillation, because when you start thinking about where we should start treating, like disease begets disease, right? So we always hear AF begets more AF, and the longer you're in AF, the longer you're going to stay in AF. Same thing for coronary disease. In every study published to date, the biggest determinant of worsened prognosis or worsened progression of disease is the baseline amount of disease. And so here I show you somebody who was analyzed in 2012, 18, 19, and 20. And what you can see is that this disease that even could have been misconstrued as an artifact was really small, and then just started growing and growing and growing over time. And so I think one goal that we have is to prove that we can halt the progression of atherosclerosis and get it at its earliest stage when it's actually treatable. And then the second goal I think that we really need to understand is that there are different types of plaque, right? And so if the yellow represents like fibrous plaque and the red represents low density non-calcified high risk plaques, we got to prevent that from happening. And instead, what we have to do is stabilize the plaque by converting it from this non-calcified into this 1K highly calcified dense calcium phenotype. Because what the prior studies have shown us is that we can achieve this, and we can achieve it in a fairly predictable fashion. And so this was really based upon a study called Paradigm. And what Paradigm did was it looked at 1,200 patients who had undergone 2 CT scans about 3.8 years apart, and then were followed for a total of 9 years for the occurrence of major adverse cardiac events. And the question the Paradigm investigators were trying to answer was, can we influence the natural history of atherosclerosis? And so what they did was they looked at 474 patients who'd never taken a statin and didn't take a statin after their CT scan, and then 781 patients who didn't take a statin before their CT, but were prescribed a statin after their CT, looking at sort of the natural history of atherosclerosis in the context of getting treated with statin medications. And what I can show you here is the summary, which is like the overall plaque volume increase was slower with statins, but not by much compared to patients without statins, which is the blue ones here. You can see the p-value is barely significant. It's only 0.04. And the reason for that is that statins actually accelerate calcified plaque formation, and they decelerate non-calcified plaque formation. They transform the non-calcified plaque into the calcified plaque phenotype. And then they also reduce the quote unquote high risk plaques that the field of CT has been calling, which is the low density non-calcified plaques. And so this actually has been repeated not only with statins, but also looking at Icosapentethyl. So Matt Budoff and Deepak Bhatt in the REDUCE-IT trial tried to see what the effects of Icosapentethyl was versus placebo. And you can see what Icosapentethyl does is it reduces plaque volume, but really reduces this low density, low attenuation plaque, as opposed to placebo, which increases those as well. It's also been looked at in the context of PCSK9 inhibitors. So in a study looking at evolocumab versus placebo, what you can see is the evolocumab over time increases the Hounsfield unit density. These numbers represent density. So the lower the number, the darker it is. The controls do nothing to it. What the evolocumab does is it takes it from that dark black plaque and turning it bright over time into calcium. And it's also been just looked at with plain old diet and DASH diet and exercise, where after a year in a randomized trial called the DISCO trial, if you were subjected to the DASH diet plaques, and then all of this shows the same themes and directions, right? We reduce non-calcified plaque, we increase calcified plaque, and we reduce non-calcified plaque and increase dense calcium. And now has been shown in statins and PCSK9 inhibitors, colchicine, NOACs, and other medications. And again, I think like where Partha sits is like he wants to figure out how to take all of this data and reduce it into an output that is clinically actionable. And I will say it's hard for us to do that, right? Like you've got percent atheroma volume and fibrous plaque and calcified plaque and high-risk plaque and all of that vascular morphology. And so like, can you actually figure out who's going to be this progressor or non-progressor depending on how you treat them just from the baseline scan? And so the paradigm investigators took the 1,000 patients undergoing serial CT imaging. They defined rapid plaque progression as increasing your plaque percent atheroma volume by more than 1% per year, in keeping with the previous intravascular ultrasound studies. And what you can see is that just doing clinical assessment, you can't figure out who's a rapid progressor. Adding in stenosis can't do it. It really, the optimal performing model is to leverage all of this stuff within the context of a machine learning model that will output, hey, this patient will be a rapid progressor or a non-rapid progressor. And I'll say like, it's starting to get pretty complicated, right? From a diagnostic paradigm that used to rely on, hey, greater than 50% or greater than 70% stenosis, or hey, I see purple on that nuclear spec scan or yellow. Like now we've got a ton of different variables that we're looking at. But what I can reassure you is that they're all overlapping, right? When you look at so this is a table of all machine learning models with feature importances ranked from most important down to least important. And whether you're trying to predict MI, whether you're trying to determine ischemia, or whether you're trying to figure out, is this patient a rapid progressor or slow progressor of disease, all of these things are overlapping. The Venn diagrams, so like are all overlapping such that all these atherosclerotic features predict rapid disease progression, medication non-response, ischemia, benefit from CAT and MACE. And so like, I think this is the new paradigm, and I'd love to hear others, because the way that I see this is that, you know, what we lacked 15 years ago was a non-invasive tool to look at primary disease. And what we also lacked was the fundamental understanding of vascular biology to understand which plaques and their phenotypic appearance and how that dictates their behaviors. But if there's any 4 things I think that you can take home from, you know, a slide like this that shows a lumen and shows all this color-coded plaque, where the red is the dark plaque, the blue is the white plaque, and then the yellow is the gray plaque, is that the darker the plaque it is, the more dangerous it is. And it's the strongest predictor of heart attack risk that we have. And then the brighter it is, the more stable it is. And at some point it gets protective against heart attacks. I haven't seen, you do see it periodically, but very rarely do you see plaque regression. Instead, what you see very commonly is plaque transformation, where medicines, diet, and exercise turn these dark plaques bright. And that's what prevents the heart attacks. So I think what we are in 2022 now armed as a field is to have an individualized, personalized approach to treating somebody and then longitudinally assessing therapeutic efficacy, right? By looking at dark plaques that are turning bright over time. So what we used to always tell the patients is like, look, we've got 2 goals here. 1, if you've got 100 units of plaque, we're going to keep it at 100 units of plaque. And 2, we're going to turn all your dark plaques bright, and that will stabilize the plaques. Because when you think about the etiology of myocardial infarction, whether it's plaque rupture, plaque erosion, or calcified nodule, they all require thin cap fibroatheroma and non-calcified plaques. Well, when you have something like this, that is essentially just a rock, rocks don't rupture, right? So this plaque cannot cause a heart attack because it fundamentally would violate the pathophysiology of MI. So I think that that's the goal here, is really to stabilize it. And we've seen that play out, right? We've seen it in the Scott Hart trial, where David Newby took about 4,000 patients presenting with angina suspected coronary disease and randomized them to a standard of care approach that included stress testing and a CT guided approach. And what he found at 5 years was a 41% reduction in death and non-fatal myocardial infarction. If you say, well, what drove such a profound reduction in adverse events? It wasn't CAS, they were the same between the groups. It wasn't PCIs, it wasn't CABG. It was all just improvements in preventive medical therapy that resulted, and that's treating atherosclerosis. That's not treating stenosis, that's not treating ischemia, that's treating atherosclerotic plaque. I think it's because of this that the UK, the European Society of Cardiology, and now, like as of November of last year, the American Heart Association, American College of Cardiology have elevated coronary CT angiography to level 1A, right, for patients with symptomatic patients without known coronary disease. And then whether it's in acute chest pain or in stable chest pain. And then for patients with known coronary disease, it's a 2A recommendation. I think that it just established CT as the standard of care globally. And then I think another notable inclusion in this guideline, it was the first time you ever saw in an HA guideline where atherosclerosis was the focal point to guide decision-making and then to prognosticate outcomes as a 2A recommendation. So I'll just conclude here by saying like 4 different points. You know, when we first started this, it was the absence and presence of stenosis that we care about. It's important. I think that in any CT scan, I think stenosis is one of the 4 major sort of risk predictors and guides our therapy, in particular to reduce unnecessary waste within the healthcare system. But it's the presence or the absence of atherosclerosis that confers the prognostic knowledge, right? We know the absence of atherosclerosis will confer a greater than 10-year warranty period, and there will be a 6-fold increase in near-term mortality, even when you don't have any severe stenoses, but you have several of them in multiple vessel distributions. And then I think where the field is going is really like, let's characterize the disease. Heart disease is not heart disease. Like there's tons of different kinds of atherosclerosis. And what we've learned over the last 7 or 8 years is that really it's the optimal method for diagnosing ischemia, for determining risk, for identifying rapid progressors. And I didn't show you the data, but also for determining who isn't going to respond to initial statin therapy that you might need in inclisiran or PCSK9 inhibitors or bempedoic acid and so on. And then finally, I will say, like, even though it seems like a lot in the context of a diagnostic paradigm that says ischemic versus no ischemic or severe versus no severe stenoses, that was a very oversimplified paradigm. And we need to adopt and embrace a lot of these atherosclerotic plaque features because we can improve patient outcomes as a result of that. And what we know, again, is that medical therapy and exercise lifestyle transforms plaque. It doesn't regress it. And that is what is associated with the improvement in outcomes. So hopefully, you know, we'll look at a day in 2032 when we'll look back at 2022 and say, wait a second, heart doctors weren't actually measuring heart disease, and we can change that paradigm and focus on atherosclerosis as the primary disease target. On that note, I'll end, and thank you very much for your attention.
Thank you very much, Jim. That was an outstanding overview. I think that's one of the best reviews of contemporary practice of atherosclerosis and coronary artery disease that I've heard in 40 minutes. And I think it's been a treat for, I'm sure, for our thank you very much for doing that. So I have a series of questions. I'm going to encourage my colleagues to post any question that they have in the chat. So first thing is, let me ask you this. If you were given all the tools to redesign the practice of how we look at coronary atherosclerosis and coronary artery disease management, and if insurance was not a problem, how would you, this is a loaded question, how would you redesign the assessment of patients coming with chest pain, and what would be your approach, contemporary approach in clinical practice?
Yeah, it's a great question, Partha. Like, I would design it so we would break down this artificial wall that says that you have to have symptoms to be sick, right? So if you think about atherosclerosis, it's a silent killer. The majority of people, the majority will never have any symptoms before they either suffer a heart attack or die from one. So, but our field is so fixated on symptom-driven care rather than disease-based care. And I think what you don't tell somebody, hey, why don't you just come when you're symptomatic with your metastatic cancer? We try to find it at its earliest state so that we can treat it when we can actually get a handle on it. We should be doing the same thing for heart disease. So the first thing I would do is say, okay, guys, let's stop talking about symptoms and let's talk about disease burden, because disease burden matters a lot more than symptoms when it comes to the real questions that matter, which is, am I going to die or not? Am I going to have a heart attack or not? I think within the context of, and so the simple answer to that is like, what we need is a non-invasive tool that's safe. We need to understand the biology, and then we need to be able to track outcomes to therapeutic success. So is the medicines I'm giving you or lifestyle that you're doing actually working or not? If you think about that, we have predicates of that, where you do advanced imaging of pathologic disease, you stage the presence, extent, severity of disease, you classify the type of disease, personalize the therapy to that disease, and do imaging again to assess the response. That's called yearly mammography. That's called colonoscopy. That's called high resolution, low dose lung CT scans with massive successes. And we don't. Like, we check cholesterol over time, and 70% of the people show up with MI have normal cholesterol. It's like, it's a senseless approach that we're doing. We need to fundamentally change that. And then you specifically asked about the symptomatic patients. So let's take that. So, you know, we were taught Bayesian pre-test and post-test likelihood, right? If you have chest pain and if it's typical or atypical angina, what's your age and gender? And we used that. But what we never taught ourselves to do was pre and post-test likelihood after you get a picture of a high-grade coronary stenosis. And so if the pre-test likelihood is intermediate, high, or whatever, and then you find a high-grade coronary stenosis, there is no non-invasive test, physiologic test, that can drive down your post-test probability to low likelihood of ischemia. None, right? You'll always be in the intermediate or the high likelihood range. So there is no sense to that. If somebody has chest pain and a high-grade coronary stenosis, send them to the cath lab. Like, that's the most efficient way to do it. You want physiologic measurements, do it in the cath lab, IFR, FFR, whatever you want to do. And so I would just obliterate non-invasive physiologic testing, because once you have a high-grade coronary stenosis in the presence of chest pain, statistically, you cannot say that that person has low likelihood of ischemia after you see that high-grade stenosis. So I'm sure two extremely controversial, I don't know, points of view, but I think they're right, guys. Like, mathematically, I think they're right. From a science perspective, I think they're right. So I think we just need to completely change the paradigm of coronary disease.
This is amazing. So are you suggesting that, if I understood you correctly, we do colonoscopy, should every person at some point in their life cycle or in their have a check? Coronary calcium score is obviously there, but maybe have a coronary angiogram, a non-invasive?
I think we need the evidence for that, Partha. I think we're accumulating that evidence. Like, we have designed a large-scale randomized control trial that we're trying to seek out funding for in collaboration with Deepak Bhatt at the Brigham, David Marin at Stanford, and then Manesh Patel and Adrian Hernandez at Duke, to answer this fundamental question of whether or not in asymptomatic people, we should be treating risk factors of disease or we should be treating the disease itself. And so we'll see, like, but if that comes out positive, yeah, then I think we should do universal worldwide screening of heart disease. Why do we screen for the most common cause of cancer, but not the most common cause of death? It's because we didn't have non-invasive tools, and we didn't understand the vascular biology, and we couldn't track therapeutic success. We have all three of those things now. Now we just need an outcome study to prove that, in fact, that should be the way that we should do things.
So we have got some very interesting questions coming up. So let me read them out. So does a polygenic risk score would add to the morphologic features for able to predict plaque progression?
I'm sorry, I'm looking at the chat part, though. I don't see the polygenic risk score.
So the James Kermel is asking, does adding polygenic risk scores would aid the morphologic assessment for understanding plaque progression? I know that there is some work going on polygenic risk scores, and how do we use that for determining coronary artery disease progression? Any comment on that?
Yeah, I mean, I think it's like, I think we need to keep that line of investigations open because it will help us do drug discovery, but I don't think it will help us prognosticate outcomes, like, because it's such a multifactorial disease, right? Like when I think of coronary disease, like the primary disease target is atherosclerosis, but it's not, it's a situational inflammatory atherothrombotic process, which means there's 4 elements there at least. There's the, hey, I'm shoveling snow or I'm yelling at my wife, and that's when I get my MI. There's the inflammation portion of it. There's the thrombosis part of it. And then there's the atherosclerosis part of that. And the atherosclerosis part is dictated in part by genetics, but also by, as everybody knows, environmental determinants, social determinants, risk factors, et cetera, et cetera. So what I like about atherosclerosis is that it's a single unified quantitative metric of the lifetime exposure of everything bad contributing to the single disease state, and I can track it over time. It's also the one that causes the MI. So I think the polygenic risk scores, I don't think are going to add much for risk prediction, but I don't think we should stop studying it, because where are we going to get our drug targets if we don't?
What's your take on coronary calcium score? It's only costing $99. Why not use that? And is that somebody's asking, is that the end of calcium score?
Yeah, I mean, if you look, Christy Valentine published a paper in Circulation about a year ago where he looked at sort of the power of zero. The power of zero is a lie. Like when you look at MESA, Cardia, Dallas Heart, Iconic, somewhere between 20 and 35% of patients who will have MI will have a calcium score of 0. And it's not just a one size fits all, it's an age dependent process too, right? So the younger you are, the more likely you are to have a coronary calcium score of 0. So if cholesterol misses 70% of people will have MI and calcium scores miss 30% of people will have MI, it's a step in the right direction. It's just fundamentally looking at the wrong biology, right? Rocks don't rupture. You cannot rupture a purely calcified plaque. That is the goal. So like, why are we, like we did a debate for ACC Education and Learning, Todd Valines and I, and Tony DeMaria was the moderator. And at the end, he asked me, he's like, well, you make a very compelling argument that we should be using this for screening, but I mean, calcium score, it's a little more convenient. Shouldn't we just a lot more convenient than a colonoscopy, but we don't do that because it doesn't work. We need to fundamentally stop taking shortcuts as a field and go to the primary disease target. That is where we will win. And until then, what we will have is another surrogate marker of risk, which has just failed us for the last 70 years. And so I think calcium scoring should die. Like, I just don't think it's that helpful. The only way calcium scoring will help you in the treatment of a patient, if you're lucky. If you just happen to be lucky to pick up a higher calcium score that happens to have a lot of higher risk plaque that you can't see off the calcium score. But if I show you a calcium score of 200 and I say, is that patient sick? Everyone will say, yep, that patient's sick. And I said, well, what if they had been on a statin for 5 years, which increases your calcium score? Or what if they ran 70 marathons, which increases your calcium score? Or what if they have gout, which increases your calcium? You just don't know if that person's sick or not. And then let's say that patient goes from 200 to 400 over time. Is that patient getting better or is that patient getting worse? Like, either they're progressing more disease or you're calcifying all their disease and transforming to stable. So you don't know. So all it does is confuse you. So I think calcium score should just die.
Wow, that's provocative. Thank you. Then there is a question about little LPA and markers of inflammation. And have you thought about integrating those along with your coronary morphology? Perhaps that's what they're trying to ask. I'm sure there is going to be an incremental value to that. What do you think?
Yeah, I think LP(a) is like highly understudied and requires a lot more study. When it is the explainable cause of MI in 25 to 33% of people, like we need to understand it better. I mean, Novartis has a LP(a) lowering agent that we should see outcomes evidence of in the next few years. I think that will be very illuminating to see whether or not LPA is a good therapeutic target as causal of MI. Until then, we know it's a increased risk of MI. We just don't have really anything like statins will increase your LP(a). The only known agent to reduce LP(a) is PCSK9 inhibitor. So whether lowering LP(a) is in and of itself beneficial, we don't know the answer, but I'm personally fascinated by the molecule because I think that it will explain premature MI in a lot of people. So, I don't think, what I'm not advocating for is throwing everything out. Like, I mean, I think we've got a lot of really good tools and we should leverage those tools. I just think that fundamentally we need to stop starting at the end of the diagnostic cascade and start at the beginning with atherosclerosis before stenosis and ischemia.
All right, so there's another question about some degree of astonishment that CT-FFR does not provide added information, and the question is why? And if FFR works in the cath lab, why does CT-FFR not work? Is it because it's a derived, is it a computational model derived? What do you think?
It's a great question. And I think that like in imaging, as Partha well knows, like we do only one of two things. We either measure something or we calculate it. And measuring is always better than calculating, because once you calculate things, you come in with assumptions. And so there's a number of assumptions through fluid dynamics that are erroneous.
I think we lost your
assume that the
oh, that's better now. Okay, we got it back.
Okay. So I think that it's a boundary conditions thing. There's too many assumptions in the calculation. Let me give you a quick example. Partha, can you hear me?
Yes, we can.
Okay. I'm going to give you an example of somebody comes in with chest pain. You do a stress test. You see anterior ischemia on the nuclear. You take them for a CT scan. They've got a high-grade LAD stenosis. You perform an FFR CT and they have ischemia. Everything works, right? Like it's high-grade stenosis, ischemia present, chest pain, everything. And then the patient's like, I don't want to go to the cath lab. And you say, okay, then we'll treat you with medical therapy. So you put them on long-acting nitrates, beta blocker, put them on a statin, send them home. And they come back in 4 weeks. And you say, well, how are you feeling? And they say, I feel great. I don't have any chest pain. I can do whatever I want. And then you put them on a treadmill and do a nuclear, and all the ischemia has gone away. That's the power of medical therapy. We know that from Courage, Berry 2D, ischemia, et cetera. Now you do the CT scan, it's going to look exactly the same as it did 4 weeks ago. Nothing changed. And so how can the FFR CT not be abnormal if it was abnormal 4 weeks ago? And what that speaks to is the lack of understanding of the boundary conditions. I don't know what the driving aortic pressure is. I don't know what the wall distensibility is. I don't know the ability to vasodilate. I don't know the distal microcirculatory resistance. I don't know any of this stuff. And if I knew it, and then suddenly the patient started taking nitrates and beta blockers, I've now lost all understanding of myocardial oxygen consumption, myocardial work. So there's just too many unknowns when you just have a picture. You can't figure it out. And so I think that's why it performs less robustly than we once thought it did.
That was a brilliant answer. And, you know, you're so very right. I was thinking when you're mentioning, we hardly look into so many aspects. There's vasomotion, there's rheology, there's blood flow dynamics, and so many factors that may alter the flow. And yeah, I think those are unaccounted for. Then, yeah, so the final question is about training. So let me ask you, and I was going to ask you a similar question. So right now, you know, we have the interventional cardiology team. So we do a lot of coronary angiograms. Do you think almost the entire coronary angiography and the interventional team should learn to do CT coronary angiogram, and that could be a good complement for their abilities to manage patients with coronary artery disease?
Yeah, I think so. Like, I mean, I think it should become the standard of care, which I think the AHA-ACC guidelines was a huge step forward for that. I think for the interventionalists, like we have some ongoing collaborations with some of the folks at MGH and sort of developing conversations with some folks at St. Francis. Like what we found was that for the interventionalists, like understanding sort of, you know, sub-millimeter level of atherosclerotic plaque informs the ability to figure out, hey, do I do shockwave? Do I do orbital atherectomy? Do I do rotational atherectomy? It pre-procedurally plans because you know exactly the length of the lesion, you know the normal reference diameters. So I think you can do a lot in terms of just improving workflow in the cath lab, particularly for patients with complex coronary anatomy, CTOs, severely calcified vessels, things like that. And then for the general cardiologist, like I really believe this, like if you do, I mean, it's not, I believe it, it's statistically, mathematically, once you have a severe stenosis in the presence of chest pain, there's no non-invasive diagnostic test that can prove that you're not ischemic. So I think it's just the chest pain. Do you have a stenosis or not? And if you do, send them to the cath lab. And in my way, there's a lower bar to get to the cath lab than traditionally. But I honestly think that if we can break down this wall that says that you have to have symptoms to be sick, cath lab's going to be busier than it's ever been because there are millions and millions of people walking around with severe triple vessel disease and 90% osteo left main. And I can give you an example. Like we have, and he won't mind because he wants us to tell his story. Like in our company, we do CT-based evaluations, and some of the employees are like, well, we just want to see what this is all about. So we're going to get our own stuff and go through the clearly care pathway. So we had a 52-year-old, completely asymptomatic, no risk factors, and then severe diffuse disease, ended up in the cath lab the following day. And then I asked him before he went, I said, are you sure you don't have any symptoms? He's like, no symptoms. And I said, okay. And I said, and I even called a bunch of people around the country that I have a lot of respect for, saying, guys, I feel uncomfortable. This guy's asymptomatic, but like, he's got, now he's like doing like all this exercise that he had never been able to do for the last decade. So I don't know if that answers your question, Partha, but I think that we think that we're really good at figuring out symptoms, like, oh, it's typical angina or atypical or non-cardiac pain. Like we don't have a great understanding of, I just can't do as much as I did 3 years ago. Like, how do you quantify that in a pre-test Bayesian way? You can. And so, and it speaks to the fact that no non-invasive tests can really get at somebody's symptoms, but once you have severe disease, yeah, you should probably treat it.
So we will end by asking you the most important question: the training programs across the country. Do you think? I think we are under training of our undergraduates, our trainees with CT, training. Certainly, we are not here offering as much of the exposure to the CT. Is this something we can tackle? Is this required to have a more focused, renewed focus? I think there are several institutions and centers across the country that provide CT program. Matt Bedoff has a program, for example, where people go for taking their level 2 or level 3 training. What should be the format of training for the future? Number one. Number two, if you've not been trained as a fellow, how should you get training? Or would there be AI to not worry about any further training? You can just get your answers by looking at AI.
Yeah, I mean, I guess I'll address the second part first. I don't think AI is going to replace the imager anytime soon for a number of different reasons. But I think what the AI will do will enable the physician to extract more out of each scan. I mean, when we were doing the research studies, it was taking us like 8 hours to make those little circles on plaque, and for a single patient, like that was never going to be anything but a research tool. So I think the AI will help make people efficient, but it's not going to replace them anytime soon. How do you train? You know, I worked at Cornell. I was in the division of cardiology for many years, and then I switched over actually to the Department of Radiology because I started to do more CT and MR and PET imaging. That was a unique situation where, you know, the departments like got along really well. The Department of Radiology chair was just an amazing leader and human. It's not that way, right? And so everywhere. And so I think where you have places where cardiologists don't have access to scanners, that's a problem. I think there's a financial misalignment where if we don't own scanners, but we own gamma cameras, then, you know, the revenue comes from stress testing. So that's got to be overcome. So I think what you're asking is a really hard question that is going to be dependent on local environments. But I mean, ESC, UK, Japan, Korea, AHA, ACC, all now recommend CT as level 1A. It's got to become the way, and it's not because I want it to be, it's because the outcomes evidence is there where you actually reduce MI. So somehow we're going to have to figure out how to be more collaborative like we were at Cornell, or cardiologists are going to have to buy their own scanners, because I think that's where you're going to get dedicated cardiology fellowship training. I think it's just going to be hard to do these hybrids where you send them to radiology for a rotation and things like that. So I don't have all the answers to that part, though, unfortunately, but I think the AI will help. And I think that the problem of training is a local one. And if you're out of training, then I think you've got those amazing courses like Budov's course, and but I don't think you're fully trained after 150 scans.
Yes.
Like, so, like, how do you do that? So so it's a tough question. I don't know the answer to that, but I think the AI certainly will make it easier for people to have readable outputs, you know, in an automated fashion.
But I would assume that people who are good interventionalists, for them, you know, to get adjusted to and adapt to looking at some of these images and scans for making clinical decision, and certainly using the AI tools to be able to work with already available images for second opinion and so on and so forth, could be very interesting opportunity to just optimize your way you make decisions for clinical practice.
I think so. The worry I have is that, like, you know, we presented the diagnostic accuracy trials and then even the ischemia trial where it looked like CT was wildly good compared to invasive coronary angiography. But when you look at the real world results, like as they did in the PROMISE trial, like human readers at the sites tend to overestimate severe stenosis by 50%. Everybody and then in the trials, it was 3 out of 3 consensus reads. So you had 3 expert core lab readers agreeing on every segment, was there a stenosis or not? That's not real world, right? So what I worry about is with the change of the guidelines, you're going to see this inflection upwards for CT utilization. And then if the prior studies hold true, we're just going to see a bunch of people without disease going to the cath lab because people overestimate disease. And as you well know, Partha, like calcium is the bane of CT's existence and causes a lot of partial blooming artifacts and like partial volume artifacts that bloom. And because of that, people who aren't familiar with CT technology will always overestimate the stenosis severity, and you'll just end up sending a bunch of people who don't need to go to the cath lab. So I think better training is required.
Great. This has been an outstanding presentation. So it's going to be stored on the website, and I think people are going to be referring to your presentation for a very long time. And we look forward to an opportunity once the pandemic ends, maybe having you here, and hopefully we'll be able to develop a robust imaging program. And we really look forward to developing the CT capabilities here at the center. Thank you very much, Jim. Thank you very much for being with us tonight.
Thank you, everybody. Have a wonderful evening.
Bye-bye.
Bye-bye.